Ladies and gentlemen, my name is Dr. Samir J. I'm anesthesiologist and intensivist. I work in Montpellier in France and I'm head of department of critical care medicine and anesthesiology. This is my conflict of interest. Severe acidosis in intensive care unit is a frequent event, ranges from 15 to 40%, which is associated with worse outcome, which mortality could reach near 60%. So, sodium bicarbonate infusion to treat severe metabolic was reported as it could be a treatment, but it remains controversial. In this observational multicentric French study, we evaluated the incidence and its association of the outcome of severe metabolic acidosis. We defined severe metabolic acidosis as a pH less than 7.2, and we reported that the patient with this severe acidosis have a mortality at 57%, which is high mortality in ICU. So when we compared the pH value evolution for the first 2 days after ICU admission between survivor patients and non-survivor patients, as you can see here, you have here the pH in the y-axis. At admission, you know the pH is less than 7.2, and the survivor patient increased slowly their pH above 7.2. However, the pH of the dead patient remained low. The same is true for the bicarbonatemia level in the plasma. As you see, a significant difference of the values of bicarbonatemia between survivor who correct their bicarbonatemia and the dead patient who remain less than 20 millimole per liter. So this is only description with no causality effect. Obviously, we cannot conclude about this, but it's just a description of what happened about pH and bicarbonatemia. So, sodium bicarbonate infusion to treat severe metabolic acidosis is always controversial, and no studies up to the last years concluded that if it was good or if it was bad or if it was natural. This is one of the first physiological crossover study, included 14 patients with acidosis, and the others evaluated the effect of bicarbonate administration on the cardiovascular organ. So the other reported no effect on cardiac output or in arterial pressure after administration of sodium bicarbonate. This is a second one study, again, a physiological crossover study, included 10 patients. Each patient was her or his one control, and again, infusion of bicarbonate sodium did not modify all the parameters of hemodynamic, such as you see here, the mean arterial pressure or the oxygen consumption or the cardiac output. In the two studies, the other reported that the PCO2 increase and also calcemia decrease. This should be obviously be careful when you administrate bicarbonate sodium. So, what about the guidelines? What about the Survivor sepsis campaign? The last Survivor sepsis campaign, and the oldest one, reported that the effect of bicarbonate administration on hemodynamic and vasopressor requirement at lower pH is unknown. So no study have examined the effect of bicarbonate administration on outcome until 2018. That's why we performed this BICAR ICU study with the aim was to determine if sodium bicarbonate has an impact on the prognostic of severely acidotic patient in the intensive care unit. Our hypothesis was that bicarbonate administration could decrease D28 mortality, or the number of patients presenting at least one organ failure at D7 as defined by a SOFA score equal at 3 or more. This slide summarizes the main secondary outcome. As you see, we also evaluated the SOFA score, the Akin score, the renal replacement therapy, the mechanical ventilation, the vasopressor duration used, the fluid loading, the values of acid-basis analysis, all the other, and also the other outcomes such as the nosocomial infection, the hospital-free days, and obviously the survival at D28. The design of the study was a randomized controlled trial multi-center study, including 26 French ICU, and we stratified 2 arms and blinded parallel arm study. This was a choice because it's not possible really to perform the blinded administration because the blood arterial gas was evaluated by the physician every 2 or 3 hours, so it's very easy to know or not if the patient received administration of sodium bicarbonate, and we have an intention to treat. The inclusion criteria were the following at the 2 days after ICU administration. So we need to have the 4 criteria must be present: pH less or equal to 7.2, PCO2 less or equal to 45 millimeter of mercury, a bicarbonatemia less or equal to 20 millimole per liter, and a total SOFA score equal or above 4 and or lactatemia above 2 millimole per liter. The non-inclusion criteria are the bicarbonate loss, which is an indication of bicarb administration, such as profuse diarrhea, such as ileostomy, and proven tubular acidosis. The second one is the chronic kidney failure needed replacement therapy, stat 4 chronic kidney insufficiency, acidoketosis, and the other acids poisoning, and the other are classical criteria of non-inclusion in such study. We evaluated 400 patients divided in 2 groups with an electronic randomization. Patient received nothing, that means no sodium bicarbonate administration, and the treatment group, who received the bicarbonate administration, as you see here, and we perform a stratification according the center and the 3 main factors, which sepsis or no upon inclusion at admission, presence or not of renal failure according the Akin score, age, elderly or not, according to less or more 65 years. This is the design of the study. After the randomization, the patients have regularly blood arterial gases, and the objective was to have a pH above 7.3. In the treatment group, as you see, we try to administrate sodium bicarbonate by some infusion at 125 to 250 milliliter each 30 minutes to 1 hour. The objective was to reach a pH above 7.3. So we repeat this to obtain this pH above 7.3 until a bicarbonate administration of 1 liter. And this, if not possible, obviously, we should consider renal replacement therapy for both groups. The results are presented here. 400 patients underwent randomization. As you can see here, 194 and 195 were included in 28-day follow-up and analysis. These are the evolution of the pH from inclusion to D7, and this you have after 4 hours, at 12, and after 1 day. You see the group of treatment administration by bicarb have a pH above, and the correction was more rapidly. This is the same for arterial bicarbonatemia. You see here the value is here, and after administration, you see in gray the bicarbonate arm. You see it's always above until D7. The PCO2 level evolution, no significant difference was observed. This is interesting to see, but please note that the patients are mainly intubated and ventilated. This is the main results. No significant difference for the composite outcome. As you see, the mortality was 0.07. However, we observed a significant difference in the strata group defined a priori with akin 2 or 3. We have a significant decrease of mortality and also, you see here, of the composite score. This is a significant decrease of mortality in not significant, but at the limit of significant in overall patients. This in the pre-specified acute kidney injury group, and you see we have a significant difference in mortality. So for all the patients and for the pre-specified acute kidney injury, we have a significant difference of renal replacement therapy requirement. Another study performed just at the same period reported the same results with a large, you see here, a large population, a large sample size. And when they compare the patient with an acute kidney injury stage 2 or more of pH less than 75, you see a significant difference on mortality of the patient who received sodium bicarbonatemia. More recently, the two papers showing that there's no significant difference in terms of mortality if we start early or a delayed strategy for the initiation of renal replacement therapy. There's a two French study, meaning that probably you could wait before start early renal replacement therapy, and maybe you could treat the patient by a test of sodium bicarbonatemia. We now have another study which is called bicarbonate ICU2, is ongoing. It's a focus on the patient with acute renal failure. This study included 1/3 of patients today in September 2020. In conclusion, bicarbonate sodium did not significantly decrease 28 mortality or the presence of at least one organ failure at D7 in the overall population with severe metabolic acidosis. However, bicarbonate infusion decreased the need for renal replacement therapy from, you see, 52 to 35%. This is a major interest to use it with no clinical side effect. And in the a priori stratum of patients with acute kidney injury, infusion of bicarbonate resulted in failure death by day 28. So we hope that we could, the second study, bicarbonate ICU, confirm this first result. Thank you very much for your attention.